curative intent in selected patients, and we'll go through who are these selected patients. And it's done in patients with controlled primary malignancy and limited metastatic burden. The goal, as inferred, is to completely remove all detectable pulmonary metastases while preserving as much normal lung parenchyma as possible. The procedure is considered when the pulmonary lesions are technically resectable. So it's not a procedure you're going to consider in a patient who you've looked at the scans and the metastatic lesions are either too much in number or just in the anatomy that we think we cannot adequately resect them successfully. And also in a patient who has adequate cardiopulmonary reserve, because of course there's no point in doing a resection if you've left a patient who you cannot get off that ventilator. And of course, in patients who there's no evidence of uncontrolled extrapulmonary disease. So we'll just define what is oligometastasis. It refers to a situation where cancer has in fact spread. So stage 4, cancer spread, but only to a small number of spots, usually one or a few. The way you would like to put it is it represents that sweet middle ground between cancer that is completely localized and cancer that is widespread. That particular spot that we aim for is a window that offers the opportunity for you to be pretty aggressive in your local and systemic treatment that may lead either to curative intent or long-term control. So the analogy I like to use is just imagine trying to control a fire. But in this case, you're at the spot where you're trying to control maybe one or two small bushfires as opposed to an entire forest fire, an entire wildfire. So that is the spot we're discussing when we talk about oligometastasis. So I hope that little analogy sort of makes it pretty clear. So like I mentioned on the slide set, we describe a state where we're just between localized and widely metastatic tumors, usually defined as 3 to 5 metastatic lesions, but the definitions vary. And just to note, while the definitions do vary, the absolute number is not as important as the biology of the tumor and the anatomical ability to resect these metastatic lesions. There's some biological heterogeneity. Some tumor clones maintain limited metastatic capacity. This is just a nod to the fact that not all tumors operate the same and not all tumors metastasize the same. So that bit of biological inherent capacity allows us to have this approach. So surgery can in fact confer some durable control and cure in selected patients. As a surgical resident and as a surgeon, I'll present the history in this sort of way. It's with all nod to my medical colleagues, this sort of came about with surgeons just being surgeons. Surgeons removed a metastatic lesion, and they observed, hey, despite what we expect in terms of the timeline of the progress of this cancer, we've done this metastasectomy, and the timeline has in fact shifted. Let's try it again, and that sort of surgical approach has led to what we see now, and the guidelines are therefore follow it. So the first person to describe metastasectomy would have been Jovan von Wickliner, and that would have been back in 1882. In 1939, Barnhill and Churchill came along, and they were the first to academically describe the first pulmonary metastasectomy for renal cell carcinoma, and that was in fact a wedge resection. Later on in 1947, the guys Hayat and Alexander, they came about and they sort of formalized the criteria for who they will, see as candidates for pulmonary metastasectomy. And they sort of put forward 4 criteria. They said the primary tumor ought to be controlled. They said there should be no extrathoracic disease. Metastases should be technically resectable. And of course, the patient should be physiologically fit. And these are sort of criteria that even now have sort of carried over. I will discuss this particular study because although it's an older study from 1997, it remains one of the foundational studies that still guides the practice, and that's the International Registry of Lung Metastases. So I have a couple of slides. We'll go through that in a bit. So how do we identify these patients? And like I just mentioned, Alexander et al., they described in 1947. Adding on that, the primary tumor should be controlled or controllable. There should be no uncontrolled extrathoracic disease except resectable or indolent lesions. Um, Lesions should be technically completely resectable and feasible with the R0 resection. And this, of course, will, like I said, anatomically would be influenced by the location of the tumors, peripheral lung versus close to the hilum, for example. They should have adequate cardiopulmonary reserve, and that will be part of your workup preoperatively. They should have favorable tumor biology, and some of the things we look at to assume uh, tumor biology favorability would be looking at the disease-free interval, um, the the slow growth patterns of the tumor, and the limited number. And then, of course, can patients tolerate a resection? Some of the contraindications or patients who we may deem not fit for same would be patients who have widespread N2 nodal involvement. That's generally a contraindication. And there are some exceptions. Patients who've had a prior pneumonectomy, so that's a relative contraindication again, to contralateral resection of pulmonary mets. And that, of course, would be on the concept of you want to make sure these patients have adequate cardiopulmonary reserve postoperatively and be able to get them off a ventilator. And the inability to completely resect all areas of pulmonary involvement. Um, Median survival with complete versus incomplete resection is 35 versus 15 months, and the 5-year survival rate was 36 versus 13%. So, and this is a quote from that study I'm going to mention in a little bit. So you can see being able to perform a complete resection as opposed to an incomplete resection is definitely one of the big prognostic factors. And just going straight into that same point, completeness of resection, having an R0 resection is in fact the strongest independent predictor of survival. And that study I've been alluding to, the International Registry of Lung Metastasis, published in 1997 in the Thoracic Cardiovascular Surgery Journal by Pastorini et al. It gave a 5-year overall survival of 36% with complete versus a 13% with incomplete, which sort of give a nod to the practice. Fast forward to 2017, Petrella et al. Came along and sort of supported that much older study, stating that the completeness of resection consistently was a dominant prognostic factor across all series, and that would be 2017 study. The number of metastatic lesions was in fact another pulmonary metastasis, and many series use a cutoff of 3 to 5 nodules for favorable biology. But again, I want to emphasize that biology trumps absolute number. Because let's say you have 6 or 7 nodules who you think you may be able to adequately resect without much limitation on the cardiopulmonary function. This in fact would be a patient you still consider for pulmonary metastasectomy. The size of the largest metastasis. So this is another prognostic factor. Larger lesions, more than 2 centimeters, associated with worse overall survival and higher recurrence in colorectal cancer, for instance, in one cohort. The disease-free interval, and this is going to be used as an indicator of the aggressive nature of the cancer. So a longer disease-free interval is associated with the best survival. So more than 36 months disease-free interval, much better outcome than, say, a patient who has a disease-free interval of under 12 months. And this was backed up again in 2021 in a study by Kanzaki et al. In the Journal of Thoracic Disease. And they concluded there that a short disease-free interval repeatedly was a negative indicator, a prognostic marker across primaries. Lymph node involvement is another prognostic factor. So with patients who've been noted to have mediastinal lymph node involvement, it also prognosticated a worse outcome. And again, several studies have backed that up. Welter et al. Most recently in 2011 was one such study. Other prognostic factors noted, biochemical markers, for instance, in colorectal cancer, where with patients who've been observed to have elevated or non-normalizing CEAs preoperatively, these were patients who were associated with much poorer survival and higher recurrence, leading back to that disease-free interval I just spoke about. Melanoma, another cancer, high LDH levels correlates with an aggressive disease and limited benefit from local therapy. All comes back again to the primary tumor histology and biology. Um, and because as you can imagine, that will be dictating the aggressive nature of the tumor. So for instance, some tumors such as pancreatic biliary, these are noted to be very aggressive GI primaries, and they're rarely considered due to the dismal systemic prognosis at the time of diagnosis. So that study I've been quoting in 1997 was the IRLM, or the International Registry of Lung Metastasectomy. It's noted to be the largest historical data set ever compiled on pulmonary metastasectomies. It was published by Pastorini et al. In 1997 in the Journal of Thoracic and Cardiovascular Surgery. The study was actually established in 1991, and the point of this study was to sort of establish the long-term results of lung metastasectomy. It's in fact a retrospective analysis. It looked at over 5,000 patients who from multiple international centers. Um, and much like what the guys Alexander et al. Identified back in 1947, it again had identified some of the major prognostic factors, which I've previously mentioned, but I'll just reiterate. Completeness of resections, you want an R0 resection, the number of metastatic lesions, and the disease-free interval, and of course, the lymph node status. What the results from the study did in fact show, and we still quote as support, is that the actual survival after complete metastasectomy was at 36% at 5 years, 26% at 10, and 22% at 15 years, with a median survival of 35 months across the tumor types. For incomplete resection, the results were a little bit more dismal, 13% at 5 years, 7 at 10, with a median at 15 months. So you clearly see the benefit among complete resections, the 5-year survival was 33% for patients with a disease-free interval of 0 to 11 months. That increased to 45% for those patients with a disease-free interval of more than 36 months. So again, it sort of showed you there again that the disease-free interval, which sort of again indicates the aggressive nature of the nature of the tumor biology, disease-free interval, of course, being one of the prognostic factors. And then the lesion numbers. For single lesions, we had over 43% 5-year survival. And when you compare that to patients who had 4 or more lesions, that survival went down to about 27%. So again, metastatic lesion number was supported there. So the multivariate analysis from this study showed a better prognosis for patients with germ cell tumors, disease-free interval of 36 months or more, and single metastasis. So from this study, we got the usually quoted survival figures of about 5-year overall survival of 36% with complete resection, 13% with incomplete resection. Even though it's an older study, and I highlight this because it's a study published in 1997, that's a pretty old study by our standards. Most modern guidelines still have not been able to debunk it as yet, and guidelines up to STS 2019 still reference concepts from this registry. So this is the study, one of the landmark studies that define the modern rules of pulmonary metastasectomy. So you've identified a patient who has pulmonary mets, and you're wondering, is this a patient, given those criteria, who may benefit some of the workup? And then the doctor surely went through a couple of the workup, but I just mentioned again, CT chest, high resolution contrast enhanced CT, primary modality, has a sensitivity that can detect lesions just about 2 to 3 millimeters or more. Excellent for peripheral nodules. PET-CT, of course, again, important in terms of excluding extrathoracic disease and detect metabolically active lesions. And again, the PET-CT can identify unsuspected metastases in 10 to 20% noted in colorectal cancer patients. And of course, you do want to do a cardiopulmonary testing because, of course, there's no point in taking this patient to the operating theater, performing a technically beautiful metastasectomy, and then at the end of the case, your anesthesiologist looks across at you and you're not able to wean this patient off of the ventilator because you've so taken down their cardiopulmonary reserve that this patient now is married to the ventilator. So those are some of the important things you want to do in your preoperative workup. The MRI, of course, does still play a role. You could do an MRI for melanoma, renal cell carcinoma, sarcoma, and even neurologic, and particularly when working up your neurological symptoms. You can do a liver MRI as well when hepatic metastases are suspected or your PET is equivocal. And there's some little nuances between the tumors. For instance, colorectal cancer, PET-CT highly useful, correlates with your CA. For sarcomas, CT chest, study primary tool. And renal cell carcinoma, PET limited, CT chest abdomen is preferred still. In terms of how we approach it, and I will not be going through the different procedure types for this forum, but I will highlight some of the core surgical principles we look at as surgical um, in surgical residents and surgical attendants in the field, cardiothoracic surgery. The goal, you want to achieve a completely macroscopic clear margin resection. You want an R0 resection. But you want this with clear consideration of preserving your maximal lung parenchyma, because of course you want to preserve your pulmonary reserve. Margin goals, you want to aim for at least 5 to 10 millimeters, but again, the biology trumps margin width. And you want to, of course, avoid excessive sacrifice of the functioning lung. It's a multifocal strategy, and while you approach this patient initially to perform a metastasectomy, in 2026, you have to anticipate that this may be a patient, if he or she meets the criteria for an appropriate tumor biology, it's met the criteria for a nice disease-free interval, you have to anticipate that this may be a patient you ask again in the future to consider a repeat resection. So you want to preserve your parenchyma early and as much as possible. Surgical principle, palpation is important. So even if you perform it via VATS, you still want to be able to get your finger in and feel. However, the argument may be made that with pretty good CT scan technology that we have now, you may be able to detect nodules that even, palpation may miss. So there is the argument on the counter side is that. But again, one of the surgical principles that is pushed is, of course, the palpation. You want to avoid a lobectomy, and certainly you want to avoid a pneumonectomy unless absolutely necessary for marginal anatomical location. But the reason for this, of course, is you want to preserve your pulmonary reserve. And I mentioned palpation already. And lymph node sampling is strongly recommended. Strongly recommended, it gives you information in terms of your prognostication and further treatment, not necessarily in mortality benefit though. Some of the other intraoperative tools that may be used in terms of localizing, maybe a fluoroscopy, hook wire localization, much like similar to breast cancer, you can have a hook wire localization. Microcoils, and you can even have other agents such as the indocyanine green, which is attached to your plasma proteins, and you can actually use that under fluorescence to find your deep nodules. Much like you would use it in cases where you do bowel anastomosis, you want to look at the blood supply. So you can use it in the cyanine green in terms of fluorescence. Intraoperative ultrasound for parenchyma navigation is also one of the tools. And these are just tools that we look in terms of being ensure that you actually get those lesions when you operate. Is there a role for repeat metastasectomy? I sort of hinted at this in a slide or two back, but you can consider it. You can consider it if, in fact, you assessing a patient who's had an adequate disease-free interval. Remember, I mentioned more than a 36-month disease-free interval is a good prognostic factor. Again, you want to look again and see if anatomically this is a technically resectable lesion. And again, importantly, does this patient have adequate pulmonary reserve? And given those things, and at the discussion at the level of an MDT, because of course, you want to discuss all these patients at a multidisciplinary team level, you make a decision as a team, surgeons, oncologists, all involved radiologists, if in fact this is a patient that can benefit from a repeat metastasectomy. And again, the outcomes, similar survival if complete resection is achievable with appropriate tumor biology. So I mentioned lymph node sampling during metastasectomy. To note, the presence of thoracic nodal involvement is associated with decreased survival, regardless of the primary tumor type. So nodal involvement, mediastinal thoracic nodal involvement, you're already looking at a case where there is some decreased survival. Systematic lymph node sampling or lymphadenectomy, it does offer additional prognostic value. However, across centers, the practice differs with some surgeons from my reading going for those lymph nodes, while others, unless they're there and easy, opt to leave them alone. But it may alter post-metastastectomy treatment planning. However, there's no data to support that the sampling or the lymphadenectomy improves survival. So just a general overall survival by the tumor type. Colorectal cancer, 5 years overall survival, 40 to 50%. And that's actually been the best studied cohort. Sarcoma is a 25 to 50%. Renal cell carcinoma, 30 to 45%, with a prolonged disease-free interval is a strongly predictive, good prognostic factor. Melanoma, not so great, 20 to 30%, but again, that continues to improve in the era of improved immunotherapy. The current guidelines and consensus by the STS, last panel from 2019, they suggested, of course, a multidisciplinary decision-making process. Again, important to sit in that room, virtual or not, and discuss the anatomy, discuss the tumor biology. You want to discuss, of course, and some of my other panelists may discuss this, like what are the other systemic options? Because that's also one of the things you have to bear in mind when deciding on just the local therapy. What are the other systemic options that can be done either pre-op or in adjunct to? You want to think of surgery. They also recommended surgery only with potential for complete resection. So if you have 5 lesions and you can only realistically with the best anatomy resect 3, there's a patient you should probably stick a pause on, take a look and look at the other options in terms of maybe radiation or your systemic therapy otherwise. Because the goal of pulmonary metastasectomy should be either towards a curative intent or maintaining as long a disease-free interval as possible. And ESMO supports the surgical resection oligometastatic colorectal consensus, sort of just nods to the STS consensus. Why is it important? And I've been mentioning the MDT and the treatment planning. You want to look at things when you sit at the MDT in terms of the patient's age. How much life do they have ahead of them, life expectancy? That makes the surgical option ideal or not. You want to look at the patient's performance status. Again, very important. And you want to look at the cancer-specific prognostic factors, which we have mentioned extensively so far. You want to look at the response to treatment. How have they responded to either systemic treatment you have given so far? And you want to look again at the remaining treatment options available on the table and contrast the pros and cons, the morbidity and mortality compared against your surgical option. The disease-free interval, important in terms of looking at the disease stability and the aggressive nature of the tumor you're particularly looking at. And of course, with any surgical procedure, you want to go look at the anticipated morbidity and mortality with the resection. And that will, of course, shift depending if you're looking at a lesion that's, say, more peripheral, or a lesion a lot more closer to the hilum, where you're looking now at more of a lobectomy as opposed to a comparatively simpler wedge resection. So those are some of the things you sit and you look at when you're planning this patient's treatment at the level of the MDT. And you, of course, you sit with your radiologist, you sit with your radiologist oncologist, your hematology oncologist, your pulmonologist, and you have a robust discussion, guided, of course, by the patient's wishes. So hopefully I have sort of elucidated or demystified what sounds like quite a mouthful, the management of oligometastatic disease, with the question in terms of the role of pulmonary metastasectomy. And if we have been following, this is actually a vignette I had posed to some residents at one point, and I'm going to pose it to the audience. Of course, I can't have you guys answer because there's no mic for you, but I'll still pose it to you. A 58-year-old male presents to you. He's had previous sigmoid colon cancer resected 3 years ago. So he's had 3 years since his last resection. That's a 36-month period. So he's completed adjuvant chemotherapy. Um, he had a surveillance CT which shows two right-sided lung nodules, and they measured at 1.4 centimeters in the right upper lobe, and it's noted. I've hinted to you it's peripheral. The second is 0.9 centimeters is deep in the right lower lobe, and the CEA mildly elevated. So I've given you quite a few things there. CEA mildly elevated. Um, Two nodules. Disease-free interval has been 36 months, and it's unilateral metastatic lesions, all unnoted on the right side. So you send this guy for a PET CT, and both nodules were PET avid. He has no extrathoracic disease that the results have come back and shows. PFTs, not bad. FEV1 82% of the predicted. He has a DLC of 78%. And you set at your tumor board, your MDT, which I've been lobbying, and you guys come up and you say you think he's a good candidate for pulmonary metastasectomy. And why is that? Why is that? I won't go into the surgical minutia, but why is that? You have a patient with two lesions. He's had an acceptably long disease-free interval. I remember we looked at the disease-free interval difference between 36 months and up versus 0 to 11 months. And this guy definitely falls into that category. He has a good functional status. And these lesions are, in fact, anatomically resectable. 1.4 and 0.9, one peripheral, one solid deep, but both anatomically resectable. So hopefully, I mean, I don't have the ability to have a vote, but hopefully this is a patient you would have thought, hey, I might refer this guy on for at least assessment of a pulmonary metastasectomy, with goals of controlling his disease with curative intent. Because like I said, many decades ago, you heard type 4, and the natural instinct was to think, oh boy, type 4 disease, stage 4, nothing more to be done. Let's palliate and wait. But now we've seen with the advent and the advances, not just in surgery, but also in the systemic therapy, that this may not be the case. So this is the sort of window I'm speaking of when I talk about the oligometastatic window. That window that allows that nice spot just between a localized cancer, which of course would be our preferred stage of getting the patient, and that state between when you have complete widespread metastases. So that is the oligometastatic window that we're talking about. What are some of the surgical things in the future that we're looking at? And I'm sure in some centers, some of these have already been implemented, but robotic assisted localization, use of robotic enhanced palpation allows you to, of course, have a fully minimally invasive approach. And then, of course, precise segmentectomy for deeper nodules without having to perform a lobectomy, because I remember at the end of the day, the goal is to preserve as much healthy lung parenchyma as possible and as surgically feasible while maintaining the outcome you're aiming for. In the cyan green fluorescence for smaller deep lesions, this is just intraoperative molecular imaging and just in terms of localization, so we can have a much better outcomes in terms of getting the exact lesions we're going for. Other hybrid approaches being looked at are some of the same sessions, CT-guided localization plus with your VATS metastasectomy, which would allow for real-time imaging confirmation of complete resection in the operating theater, as opposed to waking that patient up and then having a post-op CT to realize, in fact, he may have missed a lesion. So this is, wonderful stuff surgically. Ablation surgery combination, your radio frequency ablation or your microwave technology ablation, used for unresectable lesions and combined with resection of accessible nodules. So even those lesions now, like I said, in the future, we're looking at that sort of combined therapy, making the surgical option even wider now, against the criteria that we have set for today. So these are emerging niches in patients with and they're also emerging niche in patients with limited cardiopulmonary reserve. I'm not sure one of my other speakers would go into other systemic therapy, but those are some of the other things we look at in terms of management So what are some of the takeaway pearls from oligometastatic disease and where they look at pulmonary metastasectomy? So pulmonary metastasectomy, it's a local therapy. It only helps when disease is limited and controllable, and you've set out stating that in fact these are lesions I can anatomically resect with good R0 status and margins. Um, Appearance of multi-site recurrence, systemic process, you want to always still consider treating with systemic therapy. Short disease-free interval after prior pulmonary metastasectomy, as we highlighted. This is an unfavorable prognostic marker. So this is a patient you may again want to put a pause on, look at the data, look at the tumor biology, and say, is it worth subjecting this patient to the morbidity and potential mortality of surgery? If in fact it appears that this is a tumor that is so aggressive that I operate to them maybe in a month or 2 or 4, there's metastatic lesion. There will be metastatic lesions again throughout the lung field. So those are some of the things you have to consider. Because at the end of the day, while you want to perform surgery and do great local therapy and offer this patient the potential of cure, you also want to avoid futile thoracotomy when the biology is in your face declaring itself as aggressive. Okay? So in recurrence, you always ask, is this biology still behaving oligometastatically? And if the answer is no, surgery may be more harm than help. Okay? So hopefully this short talk helped to demystify a little bit of how we as surgeons still play a role in the management of oligometastatic disease, and how pulmonary metastasectomy is one of those tools in our armamentarium of dealing with same. So again, thank you so much for the opportunity to spend this Sunday afternoon with you, and I'll hand it back to our host.
All right, thank you, Dr. Hunt, for a very, very interesting, very useful presentation on metastatectomy. As we look across the world, we note that cancer survival rates are actually been improving. And I think the increased use of your local resection and increased use of our targeted therapy and so on with the tyrosine kinase inhibitors and immunotherapy is contributing to that. So the culture, as I've seen it, has been that stage 4 cancer, there's nothing to do. Throw your hands up, go to oncology or go to palliative medicine. So it's nice to see that there's still options and there is something we can do to help our patients. In that vein, how much are you seeing uptake? How many cases are you seeing at the university to suggest that this is something that our doctors are actually making use of?
Well, I'll tell you from experience, it has not been as much of an uptake as we would like. And again, that may be for several reasons. I mean, again, it may be, of course, with the tumor biology. Some of our patients that we see, by the time they've been referred, the metastatic burden is so heavy that, again, once you've looked at all the criteria and you looked at the imaging, that you realize it's not a thoracotomy worth the morbidity. And again, bearing in that same vein, the pulmonary reserve on some of these patients with heavy metastatic burden, again, sort of prohibits being too aggressive in terms of a resection. So it goes back to early diagnosis, which I think Dr. Rahman would have been alluding to earlier, and a stronger surveillance even in the postoperative phase. And unfortunately, we do have patients who, even after serious surgical resection for cancers, do still lapse in terms of the follow-up. So by the time sometimes they present, unfortunately, the option is off the table. But again, not as often as we would love to see it, but the option is still there.
And just to make sure we can refer directly to you guys at the university, or do we have to first go through the oncologists, go through the the other services? Can we just defer? We have a patient, they have colon cancer. We do a screening. We see, oh, there's a 2 millimeter nodule. Can we just send straight to you guys right away?
Yeah, I don't think we have a problem at all assessing at that level, especially in patients who have had diagnosed and we have the opportunity to assess for possible metastasectomy. Absolutely.
All right.
All right.
We have an attendee who wants to know what's the role of targeted therapy, right? Tyrosine kinase inhibitors, the immunotherapy, as we mentioned, as opposed to metastatectomy, right? And that's part one. And part two, should the surgical approach be a sublobar resection or lobectomy rather than pneumonectomy? Not sure if that's specific to your case or if you're speaking in general. So there's a two-parter. The first part, what's the role of targeted therapy rather than metastatectomy? And the second part is the optimal surgical approach.
All right. So it's not going to be an either or in 2026. You targeted therapy definitely plays a role, and I mentioned a little bit. Um, you want to look at the patients in terms of as well. Is there role for systemic therapy? Has this patient previously responded very well to systemic therapy? So it doesn't having the option of a metastasectomy does not at all take the role. And I'm sure someone else is presenting on those advances, but it does not take that off the table at all. In fact, it's quite a good union. And in terms of the resection type, we the surgical principle is to try and preserve as much lung parenchyma as possible. So if you can get away with great margins from a wedge or a sublobar type resection, that is the ideal, as opposed to taking out an entire lobe. And certainly, taking out an entire lung. That because once you've taken out an entire lung, you've given that patient a new disease on its own. Now having to live with one lung. So the goal, part of the surgical principles, is preserve as much as possible while resecting to an R0 resection with curative intent. So definitely great question. Thank you so much for that. Great opportunity to highlight that. We want to preserve as much healthy lung tissue as possible, because just to reiterate, in 2026, there's always the possibility of looking down the road in a patient whose biology has responded well, great disease-free interval, that this may be a patient again who may benefit from a repeat metastasectomy, given all the other parameters we mentioned out in terms of the prognostic factors are met. So you even at your index resection, you want to bear this in mind. This may be a patient, if all the prognostic factors are lined up, may need a second resection. So I preserve as much lung tissue as possible, giving that patient the chance at a secondary resection. Thank you so much for that question.
Going back to your case, the 50-year-old, one attendee wants to know, is there a role to repeat the CT at an interval before referral or just refer upfront?
In that case, that guy already had a 1.4 centimeter and a 0.9 centimeter nodule, and this was in his surveillance post-operatively 3 years out. This is the case with those size nodules, and two nodules on one side, I would go right ahead and refer that patient on.
Okay.
Yep.
You may have answered this a little bit, but I don't know if you want to add something more. But why would you warn, or why do you warn to preserve lung parenchyma? Is it because you expect the longer the patient lives, the more likely there are to be additional pulmonary mets?
Come again. Sorry, I missed that. 1 second. Tell me.
Why do you warn to preserve lung parenchyma? Is it because you expect the longer the patient lives, the more likely pulmonary mets?
Oh, okay. So you want to preserve lung parenchyma because remember the lung is going to be doing the work of respiration and of respiratory work. So you want to preserve your pulmonary reserve. You want to give this patient the opportunity to still have as normal a life after the operation, respiratory-wise, as possible. You don't want to take a patient into the operating theater to do a metastasectomy and remove so much lung tissue that that patient now has problems maintaining an oxygen level. and that patient cannot get off the ventilator because you've taken out so much lung tissue that you now basically incapacitated that patient. So the goal is to take out just enough to get your iron artery section while leaving as much healthy lung in as possible.
Do you know what the costs of the drugs are? I know that that's not specific to your presentation, but do you have an idea what the costs are?
Oh, that much I cannot help with in terms of actual cost.
Mm. Right. That's a difficult question to answer.
I'm sure one of my colleagues may have a better view in terms of the costing, but that's where the extent of my expertise would go in terms of costing.
I suspect Dr. Barnes might be able to help us, but I know that these drugs aren't cheap. They in the United States they tend to run, 20, 30, 40, $50,000 US
Yeah,
dollars
ballpark
a
figure
year.
definitely. Hmm.
So these are quite expensive drugs.
Quite
I assume
expensive.
at some point in the future they will get more affordable and then they'll be more widely available in, developing nations like ourselves, middle income nations.
Exactly. Uh,
Do we routinely utilize frozen section so that we can get adequate margins?
it's an option, but routinely no. But it's an option. Again, you once you've identified the tumor, and like I sort of highlighted some of the um, quite the newer technologies that are being used for localization. But it's an option, but no, it's not routinely. We generally aim for 5 to 10 millimeter margin, but it is an option that can be utilized.
Okay. In general, what do we use? It's just gross appearance, as you're saying, to determine the adequate margins.
Yeah, that would be it at this point. Close. And of course, we do send them off for histology and get our margins. But yeah, it goes and judging from our preoperative city planning, we aim for a wider margin, of course, while maintaining as much parenchyma as possible. So generally go up to like a 5 to 10 millimeter margin.
Okay. What's your
Mhm.
usual follow-up post-resection? What's the usual follow-up? Do they go back to the specialist oncologist, the pulmonologist? Do they stay with the thoracic surgeons?
We'd recommend a combination of both because these are patients who still would have need to be followed up by their oncologist. Because like I said, there's the marriage, of course, between the systemic therapy and the local therapy. So they'll still be actively followed up by their oncologist. Once we've operated, we will continue to follow up, and the intervals will change based on how far out from the surgery we are. A couple months in the first couple months, then we'll maybe move to 6 months. But definitely it'll be a multi-team follow-up for these sort of patients.
Okay. I see we have one question from the YouTube live stream. Just for everyone listening, the YouTube live stream is available because the meeting is at capacity. You can list your name and email address in the live stream chat to ensure that you get your CMEs. The regular Zoom chat, you will already be logged and registered. But the question from the live stream is, why does it take so long to get biopsy results? Do you have any insights on that?
Why does it take so long to get biopsy results?
Yes.
Well, that again, that's that.
Or rather, what's your time frame? What's your time frame for usually when you get your biopsy results? What's the turnaround time? Do you have any insights on how we can improve that or what might be causing a longer delay?
Mhm. I mean, certainly these are patients, and any cancer patient, I should say, these are patients who you'd have a rush on the histology, because you want to get those histology back as soon as possible. But again, though the constraints in terms of the time we get them back locally, from the pathology department, or even if it's sent privately, I guess that would be institution specific. And that much I don't be able to think I'll be able to speak to in terms of that. That would be outside there of my expertise though.
At National Chess, I mean, we get our results from several institutions. Sometimes it goes to university, sometimes it goes privately, sometimes it goes to NPHL. I think a quick turnaround time would be 2 weeks.
Mhm.
Usually ends up being 3 weeks to a month, which is unfortunately long.
Mhm. I concur, and I mean, while there's room for improvement, much credit to the system I've observed is that has drastically improved over the preceding 4 years. So I mean, it's the space for improvement in terms of the turnaround time, but that in fact that time period you've alluded to is in fact quite an improvement from what it was. So it is getting better.
Well, again, it will depend on where
And
the
yeah.
results are from, because MPHL is well known to be quite burdened, but so a private institution is usually better, but
And
sometimes you never know.
certainly at the university, that 2 to 4 week window is what we've become accustomed to at this point in terms of moving along, and it has been getting better. Kudos to this department.
All right. Yeah, are there any more questions for Dr. Hunt before we let him go? If there are no other questions, and it doesn't appear to be, we're going to allow you to go, Dr. Hunt. I want to thank you again very much for widening our horizons. We have more treatment modalities, especially for stage 4 disease, for patients who may have slow-growing tumors, small tumors, easily resectable, or what would appear to be easily resectable tumors. We have additional options. So I want to thank you very much.
Thank you for the opportunity to share Sunday evening with you, and all the best to everyone.
All right. Our next presenter is Dr. Leighton Myers. Dr. Myers will be presenting on pushing the boundaries in the surgical management of lung cancer. He's a distinguished alumnus and former valedictorian of Cornwall College in Montego Bay, St. James, and was awarded the Jamaica Government Exhibition Scholarship and went on to pursue his medical training at the University of the West Indies, Mona campus, where he earned his MBBS degree with distinction in obstetrics and gynecology. Following an initial training period in cardiothoracic surgery, Dr. Myers continued to build an extensive clinical experience in thoracic surgery and is currently a senior surgical resident at the National Chest Hospital. In 2024, he successfully completed his membership of the Royal College of Surgeons examinations and was admitted as a member of the Royal College of Surgeons of Edinburgh. Beyond medicine, Dr. Myers has a strong passion for finance and investing. He has experience in investment banking and has completed all 3 levels of the Chartered Financial Analyst CFA program through the CFA Institute in the United States. He's also a member of the CFA Society of Jamaica. He's deeply committed to mentorship and personal development. He's a lifelong music enthusiast and also enjoys sports, and proudly represented the University of the West Indies in table tennis and long jump. In his downtime, he's a devoted supporter of the Arsenal Football Club in the English Premier League. So he'll be very happy to see the Premier League results of the past weekend if he's an Arsenal supporter. I want you guys to welcome the Gunner, Dr. Leighton Myers.
Afternoon, everyone. Thanks, Dr. Samuels, for that excellent introduction. Can you hear me clearly and see my slide?
Affirmative.
Okay, so today I'm tasked with presenting pushing the boundaries in the surgical management of lung cancer. Now, this is a huge topic with many advances in many areas, and we will try to select some approaches and discuss their implications on the management of patients. Now, a brief outline, we'll look at the evolution of lung cancer surgery, look at some of the revolutionary techniques in minimal invasive surgery. We'll also look at the patient selection and the oncological adequacy, thoracic surgery after neoadjuvant therapies, which is a more newer modality, enhancement in perioperative care strategies in our surgical patients, and then we'll also look at some future directions in thoracic surgery and thoracic surgical oncology. Now, one might ask, why does this matter? Now, as mentioned in Dr. James' presentation earlier on the GlobalCon statistics from 2022, lung cancer remains the #1 ranked cancer in terms of overall incidence worldwide. It is #1 ranked worldwide in men and #2 in overall incidence in women. Now, on the local scene, as he also mentioned, it is actually ranked #4 in terms of the overall incidence in Jamaica and is in 3rd in terms of rank of cancer-related deaths. It means that lung cancer is a significant burden from a cancer disease process, and it's also of international and of local significance, and therefore significant research has been done in its advancement. Now, early lung cancer treatment would have started from the early to mid 20th century. In 1912, the first lobectomy was done for cancer by Hugh Morton Davies in London. Now, in 1933, you had the first successful pneumonectomy by Dr. Everett Graham at Barnes Hospital in St. Louis, Missouri. Now, at this time, lung cancer began as what you would call a radical approach. And for most of the 20th century, open thoracotomy and extensive resections dominated the practice. The philosophy was simple at this time: remove as much as possible to achieve cure. However, this came at a cost. It came at a cost with high perioperative mortality, significant loss of function for patients, and frequent futile surgeries due to limited staging. The problem wasn't surgical ambition, but it was a lack of biological and anatomical precision. In terms of the advent of lobectomy, so by the mid-20th century, lobectomy gained prominence as surgeons recognized, and Dr. Hunt had mentioned some of this, that removing only the affected portion of tissue, and in this case, the affected lobe, could be just as effective as pneumonectomy for early stage lung cancer, as the predominant mode of surgery in the early 20th century was pneumonectomies. William Kahans in 1960 would have published his article, and he would have shown that removal of both cancerous tissue and regional lymph nodes improved long-term survival outcomes. He highlighted the importance of achieving complete tumor resection to reduce the risk of local recurrence, and reports show that improved postoperative survival in patients who underwent this comprehensive approach compared to patients who had less aggressive surgery. Now, coming into the 20th century, towards the end of it until the early 2010s, we would have had the advancement of, or a move from conventional CT scans to the helical or spiral CT and multi-detector CT scans. And some of these would have been mentioned, as we know the management between surgery and pulmonology have some overlap, and Dr. Shirley would have mentioned some of these, so we will quickly mention. The PET scan, which has significantly improved diagnostic accuracy in terms of staging of patients. And as you had mentioned, the CT-guided biopsy as an approach that have impacted and helped in terms of adequately diagnosing patients, especially those who have smaller lesions. So with these advanced CT scans, we now have an increased pickup rate. So a number of patients would have now been diagnosed with lung nodules and lung tumors, which would have otherwise been missed. It caused increased detection of smaller lesions, as we mentioned. These could have caused improved diagnostic accuracy of early stage lung cancers. And what all of this basically caused was a broadening of the pool of operable candidates. You had a number of patients who were now at higher risk, and also a number of older patients. And these would have been mentioned from the screening techniques as well that was mentioned by Dr. James earlier. This is a picture showing just an image of a PET CT scan. What it highlights is a patient who was known to have a lung tumor from the CT scans. However, when the PET CT scan was done, it had not only shown uptake from the lung, but an incidental finding of a focal uptake in the proximal duodenum, as well as splenic uptake and significant increase in terms of bone marrow uptake. And with the advent of PET CT scans, many patients who were deemed to have early stage disease were later found to have disease elsewhere, which would have actually resulted in upstage of their disease. During this time, we also had the advancement in terms of endobronchial ultrasound. Again, we won't spend long on this point, and especially when it was combined with transbronchial needle aspiration. This was instrumental in navigating and investigating the mediastinum, which had caused a push away from the conventional mediastinoscopy, which would have put patients at increased risk. You now had a much less invasive minimal approach, which could give you basically the same information in terms of diagnosing and staging the mediastinum. And it's shown that EBUS with the transbronchial needle aspiration is highly sensitive, approximately 89%, and has a negative predictive value of 91% for nodal staging, often detecting cancer spread not visible on CT or even PET CT scans. Now, The discussion in terms of advancement in surgical techniques is centered primarily on patients with resectable disease. And these are patients, according to the 9th edition of the TNM by the AJCC, the American Joint Committee on Cancer, and the Union for International Cancer Control, or the UICC, is diagnosed as patients with stage 1 to 2 disease and select patients in stage 3B. Now, just to highlight one important update in the 9th edition, which took effect on January 2025, is that it now distinguished for nodal disease, specifically the N2 disease, into N2A and N2B. And this was done because there was prognostic indication value in separating patients who had single stage non-bulky mediastinal disease from those who had multi-stage mediastinal N2 disease. And we'll mention it quickly later on in the presentation, what the significance of this change meant for patients. Now, surgery remains a cornerstone for curing early stage non-small cell lung cancer. Early resection offers the best long-term survival for stage 1 to 2 disease and select 3A cases, as we mentioned earlier. However, several challenges still exist in achieving optimal outcomes for all patients. Patient selection criteria. Now, many patients are deemed inoperable due to comorbidities, poor pulmonary function, or advanced disease stage, limiting surgical intervention to a select population. Surgical complexity. Central tumors near vital structures and cases requiring extended resections pose technical challenges that demand exceptional surgical expertise and specialized techniques. In terms of postoperative recovery, conventional surgery often results in significant pain, prolonged hospital stays, and delayed return to normal activities, impacting quality of life and treatment timelines. And in terms of oncological outcomes, achieving complete resection with adequate margins, as we mentioned in the previous presentation as well, whilst preserving lung function remains a delicate balance, particularly in complex anatomical locations. Now, these limitations have driven the development of innovative strategies in terms of surgical management and an expansion in the boundaries of resectability, whilst aiming to improve patient outcomes. And in that move to improve patient outcomes, we would have gone to the advent of, should a patient have a lobectomy versus sublobar resections? And lobectomy with mediastinal lymphadenectomy had and then became the gold standard due to superior local control versus sublobar resections. Sublobar resections include non-anatomical wedge resections and the more anatomical segmentectomy. The segmentectomy being anatomical oncological resection where the bronchopleural segments are removed, including the associated blood vessels and lymphatics. And in doing so, you can achieve an oncological resection by removing a smaller portion of the lung as compared to traditional lobectomy. Now, the evidence to support the push towards sublobar resections is extensive, and we'll review some of the literature here. Now, the Lung Cancer Study Group in 1995 established that lobectomy as the preferred treatment for early stage T1N0 stage 1 disease in non-small cell lung cancer patients by demonstrating higher local regional recurrence rates associated with the sublobar resections. However, this long-standing preference had been challenged over the years, and additional research into sublobar techniques has emerged. The evidence in the lung cancer group also showed that there was a 3-fold increase in the wedge resection group and a 2.4-fold increase in terms of local regional recurrence in the segmentectomy group. Further evidence, the Japanese Clinical Oncology Group in 2022 would have done a trial, which was a randomized control trial that compared segmentectomy to lobectomy in patients with small peripheral non-small cell lung cancer tumors which were less than 2 centimeters. And what they found was that overall survival was improved in the segmentectomy group, but the local recurrence rate was slightly higher than lobectomy group, which was 10% versus 5.4% respectively. This finding underscores the challenge of achieving equivalent oncological outcomes with sublobar resections in terms of local control and long-term survival. Further studies by the Japanese group, the Japanese Clinical Oncology Group, further in 2023, went on to do another trial which compared segmentectomy with wedge resection in patients who had peripheral ground glass opacification dominant stage 1A, non-small cell lung cancer, again sizes less than or equal to 2 centimeters. And what the study confirmed then was that segmentectomy provided superior local control and overall survival compared to wedge resection, reinforcing segmentectomy as the more oncological sound choice for small peripheral tumors, which we knew from the anatomy, it being an oncological resection, we expected to outperform wedge resections when it comes to disease-free survival in patients and increase or decrease level of local regional recurrence. Now, the evidence continued, and the Cancer and Leukemia Group B, the CALGB group, in 2023 did a large randomized trial comparing lobectomy with sublobar resections, either segmentectomy or wedge resection in patients, again, stage 1A non-small cell lung cancer. As you'll find, a lot of the research into these smaller resections are always with early stage disease with predominantly small peripheral tumors. And what this study showed was that sublobar resection was non-inferior to lobectomy regarding overall survival and also overall disease-free survival. Additionally, it highlighted the functional benefits of sublobar resections, including better preservation of lung function, which was being stressed in the previous presentation by Dr. Hunt as well, and fewer complications. Although the local recurrence rate was slightly higher in the sublobar group, approximately 7% compared to 4% for the lobectomy group, it was found that this increase was not statistically significant. And finally, in 2024, the Society of Thoracic Surgeons database analysis would have had an extensive database analysis comparing sublobar techniques, which are segmentectomy versus wedge resections in patients, again, early stage 1 disease, non-small cell lung cancers with tumors less than 3 centimeters, which again found that wedge resection was equivalent to segmentectomy in this study, however, for clinical stage 1A disease, and suggested that wedge resection is a viable option, but usually limited to patients who are high risk and may not be able to tolerate lung resection well. With the push to advanced surgical offerings, we had the emergence of minimal invasive thoracoscopic surgery. And the first one was the video-assisted thoracoscopic surgery, or commonly known as VATS. And what this is an anatomical resection which is performed by a surgeon, usually via 2 to 4 small incisions on the thorax. You have an insertion of a thoracoscope or the camera, along with endoscopic instruments, and those are used to perform different surgical techniques. In this case, for lung cancer patients, both sublobar resections, lobar resections, and even sometimes, as needed, pneumonectomies. Now, the benefit is that during the VATS procedure, the ribs are not spread. This is done in conventional thoracotomies, and this is a significant cause in terms of patients' postoperative pain and also increase terms of reduction in their postoperative FEV1. Now, the indications for VATS is usually, in terms of lung cancer, is usually in early stage non-small cell lung cancer, again from stage 1 and 2, and selected stage 3A cases. It's increasing, and also it's been increasing the use of complex resections such as sleeve and post-induction surgeries, which we will go into later on. Now, with the emergence of minimal invasive surgery and VATS, the studies would have shown significant benefits. These include decreased perioperative morbidity, decreased postoperative pain, a lower rate of pulmonary complications. We noticed a decrease in the length of stay in hospital and a faster functional recovery. And these benefits from minimal invasive surgery would have pushed the advent of minimal invasive surgeries, and it didn't stop at VATS, as we'll see later, with also newer technologies being developed. A few studies which have compared, here we mentioned Ben Dixon et al. In 2016, demonstrated that reduced pain and improved early quality of life in patients who had VATS compared to thoracotomy. The Violet trial in 2022 was a multi-center randomized controlled trial comparing VATS and thoracotomy lobectomy in early stage lung cancer. It demonstrated better recovery in patients' function at 5 weeks post-operative. There are also a few meta-analyses done of randomized controlled trials, and they all consistently showed short-term clinical benefit with oncologic non-inferiority. And this has made VATS the recommendation for surgeries once feasible and available. Now, Uniport VATS is a step further in which the Uniport VATS represents evolution in minimal invasive thoracic surgery. Complete lung resections can be performed through a single incision, typically 4 to 6 centimeters. Now, this technique reduces surgical trauma, postoperative pain, and recovery time whilst maintaining oncologic radicality. The single port approach requires advanced surgical skills, however, and specialized instruments, but offers superior cosmesis and reduced intercostal nerve injury compared to multi-port VATS. There's growing evidence supporting its safety and efficacy for anatomical lung resections in appropriately selected patients. And this is a picture showing what it would look like. So unlike the traditional VATS with 2 to 4 ports, one single port is used where the thoracoscope and the endoscopic instruments are inserted through a single incision. Now, the development continued, and then we saw the advent of robotics. Robotic-assisted thoracoscopic surgery, or RATS, combines the advantage of VATS with enhanced precision and dexterity. Now, it represents a paradigm shift in minimal invasive thoracic surgery, and it combines the advantages of VATS. The Da Vinci surgical robot system provides a 3-dimensional high-definition visualization and wristed instruments that mimic human hand movements with greater range and precision. What it leads to is improved visualization of the mediastinal structures and lymph node stations. It enhances instrument precision for delicate dissection and reconstruction, reduced postoperative pain and analgesic requirements, leading to a shorter hospital stay compared to open thoracotomy and quicker return to function. It has comparable oncological outcomes to traditional approaches, and also a novel approach is remote capabilities. It's noted that the first documented one, which I saw in literature, was in 2024. In July, surgeons in Shanghai successfully performed a remote lobectomy and lymph node dissection in a patient in Xinjiang, which was actually 4,000 meters away using 5G powered robots. Now, this basically introduces the advent of remote surgery, which is being done in specialized centers in specific circumstances. And this also has been noted in the United States as well. Now, for the robotic associated thoracic surgery, or RATS, the surgeon is in A, you'll see the surgeon sitting inside a console. That is where it controls the arms which are over the patient, seen in picture B. And C and D are showing different approaches. But the surgeon in picture A at the console can be either in this close to the patient in a similar suite, or as been demonstrated in China and the US, he can be as far as thousands of meters away. Now, this revolutionary technique has come with some limitations, however. There's a significant cost, and this makes it prohibitive in certain centers. It's usually only seen usually at high volume specialized centers and usually in first world settings. There's a significant learning curve as well, approximately 20 to 40 cases with a longer setup time and limited tactile feedback, which is the point where VATS takes a benefit where the surgeon can still have some tactile feedback while performing the surgeries. Now, in terms of the evidence behind RATS, predominantly is retrospective and propensity matched cohorts and minimal database studies. However, oncologic outcomes appear non-inferior and perioperative recovery generally better with RATS compared to open lobectomy in carefully selected patients. There's ongoing research with robotics, many in the early stages, but as time progresses, we will see more level 1 evidence coming out to support the use of RATS in surgery for lung cancer patients. Now, robot-assisted bronchoscopy has also been performed. It now provides enhanced stability, precision, and the ability to reach the outer third of the lung, which was previously difficult to access It uses a steerable robotic-controlled catheter to locate the lesion, and studies indicate that robotic-assisted bronchoscopy is comparable or even better in terms of diagnostic yields for peripheral nodules compared to other advanced bronchoscopy techniques such as electromagnetic navigational bronchoscopy, which I think was mentioned in the presentation before Dr. Shirley. But ENB is really just where they combine CT scan with electromagnetic technology to guide the catheter through the airways, thereby reaching more peripheral nodules. However, with rats, they've been able to reach nodules which are even further in the periphery with a robotic-assisted bronchoscopy. Now, expanding resectability. Now, with the advent of technology, patients who were previously deemed to be unresectable have now been offered surgical resection with curative intent. Now, sleeve resections and bronchoplasty techniques have revolutionized the surgical management of central lung tumors, enabling curative resection whilst preserving lung parenchyma. Previously, patients who had central tumors which were very close to the carina were deemed inoperable and went on to get definitive chemoradiotherapy and immunotherapy as indicated. Now, these procedures now with sleeve resections and bronchoplasty avoid the need for pneumonectomy in these patients, in selected patients, and significantly improve postoperative pulmonary function and quality of life. When technically feasible, it's recommended that it should be the standard of care for central tumors. And this is a picture showing, well, in this case, it was a combined sleeve, but previously a tumor such as this one close to the carina, which is at the bifurcation of the trachea, these would have been deemed inoperable. Now with the sleeve procedure, the bronchus is separated, the tumor is removed, and then you have reanastomosis of the bronchus, and in this case, the artery, which was also being affected by the tumor, was resected, and then once the tumor is removed, then the anatomy is then reconstructed. This has provided benefit for patients with central tumors who were previously deemed inoperable. Now, a topic of discussion in thoracic surgery and lung surgery has always been the N2 nodal disease. Should we operate on these patients? And this was also had prompted the revision in the 9th edition of the TNM staging, why N2A disease was specified compared to N2B disease. Now, in the intergroup trial and in the ESPA2 trial in 2015, the intergroup trial had shown that there was actually no overall survival benefit in the group that underwent surgery with N2 disease. But when they did a subset analysis, the lobectomy subgroup had shown improved overall survival. However, the pneumonectomy group had shown increased perioperative mortality. In the ESPA2 trial in 2015, it showed that patients who had post-induction resectable stage 3 tumors, they were randomly assigned to either definitive chemotherapy or surgical resection. And this trial showed that the 5-year overall survival and progression-free survival rates were excellent with both definitive chemotherapy and surgery, which basically indicated that N2 disease can have successful surgical management, unlike previously thought in the intergroup trial, where it suggested that this was not the case. Now, the general consensus guideline, which is combined from the National Comprehensive Cancer Network, the NCCN, the European Society for Medical Oncology, the American College of Chest Physicians, and the British Thoracic Society, has suggested that surgery may be considered in these patients once there is single-station, non-bulky disease, called N2A disease, good response to induction therapy, lobectomy is actually achievable, and once these patients are managed in experienced multidisciplinary team centers. Now, the theme throughout the entire presentation and in all the advancement has always been that all decisions should be taken at the MDT level. This has also proven to have increased outcomes in terms of careful patient selection and improved survival advantage post-treatment. Other surgeries which have been considered are extended resections and reconstructions. Now, extended resections push the boundary of lung cancer surgery, offering curative potential for previously deemed inoperable tumors as well due to local invasion, similar to those with the sleeve procedure. So these complex procedures require multidisciplinary team expertise, meticulous surgical technique, and reconstruction of involved structures. These include extended pulmonary resection, which include resection of the lung parenchyma, as well as structures such as the pericardium and diaphragm, or even major vessels. In terms of chest wall reconstruction, which speaks for itself, patients who have tumors which have involved the chest wall have gone on to have successful surgery with removal of the or resection of the chest wall, and then reconstruction with using either prosthetic mesh, methyl methacrylate, or autologous tissue. This maintains the structural integrity and protects the underlying organs. There's also combined vascular reconstruction, which involves resection and reconstruction of pulmonary artery and vein segments involved by tumors, utilizing end-to-end anastomosis and interposition grafts or prosthetic conduits to restore vascular continuity. And again, these techniques have expanded the offerings, and the patients who were previously deemed inoperable are now able to undergo surgery with curative intent. And one thing that was noted in literature during the resections was the use of novel asymmetric linear staples, or your NALs. And what this is an innovative surgical instrument which is designed to improve oncologic outcomes in lung cancer, particularly in sublobar resection, which is being advocated today strongly. And what it does is address the limitations with the conventional staplers that we use at surgery. And just to put it shortly, what it does is that it reduces the squeezing artifact or tissue damage and allows a better pathological evaluation for frozen sections during complex resections where intraoperative confirmation of R0 or complete resection is needed. It also knows that the ability of NALs to provide on-cross specimen is of significant value in complex bronchoplastic procedures like sleeve resections. Now, for patients who were previously deemed inoperable, especially stage 3 disease, we now have the combined approach of neoadjuvant immunotherapy and targeted agents and surgical resection after induction. And this has also increased the amount of patients who are now able to undergo surgical resection. Two quick examples there, durvalumab and chemotherapy is now FDA approved for neoadjuvant and adjuvant therapy in patients with non-small cell lung cancer who are resectable. And pembrolizumab, which is a PD-1 inhibitor, has been approved. And there's significant research with pembrolizumab as a PD-1 inhibitor to the point where it has now been advocated as a standard of care for all non-small cell lung cancers which lack targetable mutations. It is also the first-line treatment for tumors which express a high amount of the PD-L1 tumor. These are increasing the use of chemoimmunotherapy, which has shown to downstage tumors, potentially converting otherwise unresectable disease into operable scenarios. Now, combined with this new approach to providing surgeries to patients who were previously deemed inoperable are the strategies in and around the management of patients in the perioperative period. And that's related to the advent of ERAS, or Enhanced Recovery After Surgery protocols. And these have transformed the perioperative care in thoracic patients, systematically addressing factors that influence recovery. And in terms of ERAS for thoracic surgery are in 4 arms. You have your preoperative optimization, the minimal invasive technique, your perioperative management, and your post-operative care. Now, in terms of your preoperative optimization, patient education, nutritional assessment, cessation of smoking and alcohol use, and pre-rehabilitation programs including respiratory exercises and physical conditioning. These have shown to improve patients' outcome post-surgery. In terms of minimal invasive techniques, it is advised that VATS and RATS should be used where feasible, and there should be meticulous surgical technique to minimize tissue trauma. In terms of the perioperative management, goal-directed fluid therapy, restrictive transfusion protocols, multimodal analgesic minimizing opioid use, and early mobilization protocols are also shown to improve patients' outcome. In terms of the immediate postoperative care, early feeding, chest physiotherapy, aggressive pulmonary toilet, and standardized discharge criteria promoting timely hospital discharge, reducing length of stay in hospital, has shown to improve patient outcome. Now, we look at some of the future direction in terms of lung cancer management. I said that the advances in surgical management of lung cancer is extensive. We would have limited to the ones that are more common, and we will go through a few of these now. We have mentioned electromagnetic navigational bronchoscopy before, but what is happening now is that these are now being integrated with preoperative CT imaging and then real-time instrument tracking, providing three-dimensional guidance during surgery. So unlike before, where patients are being operated on, as with Dr. Hunt's presentation, relying on either imaging or tactile field, we now have combination systems with navigational bronchoscopy to guide real-time surgery. And these result in more accurate location of lesions, which confirm complete removal intraoperatively, and this reduces the risk of positive margins and reoperations. Now, in terms of intraoperative, in terms of integration of technology with lung cancer, we now have real-time imaging modalities. Now, there's intraoperative imaging techniques, which provide immediate feedback on resection completeness and margin status. And a few of these would have been mentioned in Dr. Hunt's presentation as well. Fluorescence imaging using indocyanine green highlights the vascular supply and identifies anatomical variations, while intraoperative ultrasound aids in the assessment of tumor extent and margins. We've also seen where portable CT scanners in the operative theater enable immediate confirmation of resection adequacy, particularly valuable in cases of complex reconstruction surgeries. In terms of a few more novel non-surgical modalities, which we have seen in patients with early stage non-small cell lung cancer who may be deemed inoperable, microwave ablation has now emerged as a suitable option for patients who have early stage disease as compared to radiofrequency ablation. It's shown that microwave ablation is showing promise in a 3-year risk-free survival in high-risk early stage lesions with favorable complication profiles, and it also shows a faster recovery. The integration of ablative therapies with surgery may push boundaries for patients unfit for traditional resections. A few other future developments, we're now seeing the advent of molecular profiling in terms of liquid biopsies. And liquid biopsies analyze circulating tumor DNA or ctDNA from blood samples, which offering a non-invasive tumor characterization and real-time monitoring of treatment response and minimal residual disease. Now, in terms of minimal residual disease, this is used to basically monitor for neoadjuvant therapy selection and surgical timing. Patients who've undergone surgery are monitored for their ctDNA levels, and these may actually show elevation, which would otherwise be unable to detect on radiography. So what they found is that by monitoring the levels of the ctDNA, they're able to predict recurrence even before it's actually shown on imaging. And in terms of adaptive surgery, real-time molecular analysis guides extent of resection, lymphadenectomy completeness, and the need for adjuvant therapies, optimizing individualized treatment strategies. Now, we are in the advent of AI, and AI has been added to the modalities for surgical management. Artificial intelligence algorithms are now being developed to predict surgical complexity, optimize operative planning, and forecast post-operative outcomes based on preoperative variables. We've now also seen intraoperative mass spectrometry, which enables real-time tissue characterization, whilst augmented reality systems overlay the preoperative imaging onto the surgical field, enhancing spatial awareness during complex reconstructions. And these innovations promise to further expand the boundaries of resectability whilst improving precision and patient outcome in lung cancer surgery. Now, a lot of the advancements and pushing of the boundaries mentioned would have applied to mostly the first world setting, as we have a number of limitations in Jamaica. I will just highlight a few of those. Most patients, and it was shown in the presentation from Dr. James, that when we only did 8 lobectomies, and this is due to the fact that most patients that we see, especially at National Chest, with lung cancer present with advanced disease. There's also no widespread lung cancer screening program. There's limited access to PET CT scans or CT scans and endobronchial ultrasound. It also was mentioned about the delays in pathological turnaround, which basically delays the patients getting their whether induction, neoadjuvant therapy, and also in terms of adjuvant therapy. There's limited availability of molecular testing. Most molecular testing is done overseas, usually at University of Miami. There's limited access to thoracic surgical care, which is currently only available at the University Hospital of the West Indies and the National Chest Hospital. For more complex procedures, there's a limitation in terms of ICU beds and HDU beds. And this limits the number of complex procedures that can be done. Patients, especially those who are high risk, that may need complex or even lobectomies or pneumonectomies, usually will require ICU coverage, which is limited in our patients as they're only available currently at KPH, Kingston Public Hospital, and the University Hospital of the West Indies for our thoracic surgical patients. In terms of advancing therapies in minimal invasive surgery like VATS and RATS, these come with significant costs and equipment barrier. And currently, VATS is available only at the University Hospital of the West Indies. It should be available soon at National Chest Hospital as well. And as we know, RATS at this point is completely unavailable. And so as we push the boundaries for surgery internationally, we will hope to push the boundaries of our offerings in Jamaica as well. With the advent of at least VATS, which is now available at UWI and soon to be available at National Chest, we hope to see a push towards a significant increase in the number of minimal invasive procedures done for patients with lung tumors and resectable lung cancer. So, in summary, lung cancer remains the leading cause of cancer-related deaths worldwide and ranks number 3 in Jamaica. New technological advances have increased the pool of patients diagnosed with early-stage lung cancer. We note that poor pulmonary function and high-risk patients have prompted a push towards sublobar resections, especially those done via minimal invasive strategies such as VATS and RATS, in terms of video-assisted and robotic-assisted thoracoscopic surgery. Jamaica currently faces a number of limitations in the push to advance surgical treatment of lung cancer, and significant funding will be needed to expand the offerings of local thoracic surgeons. Novel approaches such as liquid biopsies and adaptive surgery are also paving the way for advanced therapies. And these are my references. Thanks for allowing me to present today. And if there are any questions, we can take them now. Over to you, Dr. Samuels.
Thank you, Dr. Miles. That was a very good presentation showing us what's there on the frontiers of medicine in terms of treating lung cancer. And indeed, what National Chest itself, with the advent of VATS at our institution, can expect to be doing, some of what we can expect to be doing in the next coming months and years. If there are any questions, please type them for the Q&A section. Those in the YouTube chat, the YouTube live stream can also type their questions as well. Our first question from one of our attendees: if an individual has a strong family history of cancer, do you think it is advisable for them to have a PET scan as a routine screen for cancer? Some of what Dr. James went through coming out again, but do you think you'd advise PET scan for routine screening of lung cancer for patients who have a strong family history of cancer?
So in terms of the preoperative work of patients with lung cancers, you'll find that in most treatment protocols now, patients with strong family history and even those without a strong family history are encouraged to have PET CT scans as opposed to just conventional CT scans. As I'd highlighted in the early slide, sometimes from a regular CT scan, it may show a single lesion in the lung. However, once you get the molecular scan, which a PET CT scan is, it will actually show uptake or could potentially show uptake in other areas which were missed by the CT. And then those areas would now have to be investigated to ensure that this is actually a patient with early stage disease and not someone who has advanced disease, but is just not being shown by your less sensitive imaging, such as your conventional CT scans.
But this is in the treatment. This is the treatment of lung cancer, or the workup of lung cancer, but in terms of a routine screening test.
Or screening. No, well, if you're saying screening, then these are patients who aren't known to have the disease. I thought you mentioned in terms of the treatment. So if it's screening, then the indication is a low-dose CT scan. That's the current recommendation for screening. As remember that screening will be patients who have no current symptoms, and the screening protocol currently will have low-dose CT as a screening modality. However, patients who have a strong family history should, however, get molecular testing, which is what has been advocated early in the management, because this will actually clue you into molecular changes, which can have more targeted approach, as patients with significant family history may have mutations. So I would say that mutational screening would be added to those patients primarily, as opposed to an early CT PET.
Okay. So if it's screening, we're saying low-dose CT scan, and if it's the management of lung cancer itself, especially with or without family history, the CT PET scan is ideal.
Yes.
All right, thank you. Is there a role for the cardiothoracic surgeon in the treatment of pulmonary embolism? I'm assuming looking at the complications of cancer now. Is there a role for the cardiothoracic surgeon in the treatment of pulmonary embolism?
Well, in the treatment of pulmonary embolism, there are many areas, but one area which we tend to get involved with significantly at National Chest Hospital, though we do the surgeries at KPH, in terms of patients who have pulmonary embolism, especially those who may have failed conventional anticoagulation, or patients who are going for high-risk procedures, which we're deemed significant anesthetic risk. They may need what they call intravenous or IVC filters placed. And those we've been doing at a higher rate over the last few months, where patients with pulmonary embolisms have needed IVC filters. In patients who have massive embolism, there are also approaches or areas where a cardiothoracic surgeon may be involved in terms of treating these patients as well.
Which surgical intervention and medical treatment is required for a 45-year-old man with non-small cell lung cancer, for example, with underlying emphysema?
Sorry, repeat.
So Dr. Gadi is asking, which surgical intervention medical treatment is required for a 45-year-old man with NSLC with underlying emphysema? So a 45-year-old with emphysema, and they're wondering what's the best surgical intervention that can be offered.
Well, if you have a patient who has emphysema disease, before you could determine the best approach, these patients will definitely need to get extensive preoperative assessment. Patients with emphysema will have, or usually have, decreased pulmonary function. And so these patients will have to go through the gamut of pulmonary function tests to, one, determine their suitability for surgery. These will include their spirometry and their DLCO, the FEV1 DLCO, which may or may not go on to cardiopulmonary exercise testing, as these patients have to be stratified in terms of the surgery. Now, once these patients are deemed operable, early stage disease, and are going for a resection, you'd want to tailor an approach that involves more of a sublobar approach once it's possible. As we know, in patients with emphysematous disease, the smaller the resection will improve their postoperative FEV1 and their actual pulmonary reserve and function post-op. So in these patients, primarily, you'd want to get a minimal invasive if possible, and you'd want to get a sublobar approach if feasible for these patients. You want to remove as little lung as possible to achieve an oncologic resection.
Okay. One attendee was advising that they may need echo as well. So in terms of the preoperative assessment.
Sure. I mean,
all right. I want to thank you, Dr. Myers, again for your excellent presentation. If there are no more questions, Right. If there are no more questions, we'll allow Dr. Myers to go. At this time, I want to ask Dr. Lowe if he'd be willing to make a few comments. Dr. Lowe is associated with the Caribbean Association of Oncologists and Hematologists. They are part of one of the institutions who are sponsoring this presentation, this conference for us today. So we're just asking him to say a few words on behalf of Dr. Nimrod, who's unable to attend. Dr. Lowe?
Yes, good afternoon. Thanks, Chair. Good afternoon, everyone. Thanks for having me. So yes, I'm really wearing the hat of the clinical chair for the Caribbean Association for Oncology and Hematology. Bringing greetings from the organization, and firstly to apologize. Dr. Nimrod, the current CEO, was unavoidably absent due to personal emergency. But I would like to extend gratitude to all the collaborating institutions, Jamaica Cancer Society, Hope Institute, National Chest Hospital, as well as all of our esteemed presenters so far and left to come. And of course, the attendees who have turned out in significant numbers, quite impressive, to facilitate this very important forum on lung cancer. It really is fora like these that underpins CAHO's collaborative and supportive role towards improving cancer care in the Caribbean. So while we'll be focusing, or we have focused on lung cancer here, collectively we would want to improve cancer care throughout all the different types of cancers. So we do this by bringing together this similar approach, a multidisciplinary panel of experts. And in this case, it's going to be from different member states. So Jamaica participates, Trinidad and Tobago, Barbados, Bahamas, St. Lucia. And the whole purpose is to develop guidelines. So we've done this in 2018 in collaboration with NCCN for harmonized screening guidelines and treatment guidelines for the Caribbean. And it really helps to inform or guide policy development in the region. We also work in country, so we work and partner with other countries. So we have different MOUs with different countries to see if we can help to bolster important things like cancer registry. So quite a few of the presenters would have spoken earlier about lack of data. And this is an important area, a gap that needs to be filled in terms of ensuring additional information or appropriate information in terms of the research for our population. Our Afro-Caribbean population, they're underrepresented in international research. And so we need to know what's happening with our patients. In-country guidelines are important as well. And so as we speak, this is what we're also driving and developing in the different Caribbean states. So just grateful for this opportunity and a forum like this to bolster the collective work that is needed. And we're particularly encouraging the younger experts, some of who are participating in these panels now, to be a part of that organization to help to drive the work and the important work that we have to do. So thanks again. Thanks for allowing us to partner with this important initiative. And we look forward to continuing the work that lies ahead. Thank you.
Thank you very much, Dr. Lowe. All right, moving to our final topic for today, last but not least, the role of AI, artificial intelligence, in oncology care today, as presented by Dr. Tony Barnes. Dr. Barnes is a medical doctor specializing in hematology and medical oncology. She received her training at the University of the West Indies Faculty of Medicine and graduated with a Bachelor of Medicine, Bachelor of Surgery in 2012, and completed her internship and senior house officer training at the Cornwall Regional Hospital. In 2015, she started postgraduate training at the University Hospital of the West Indies and worked as a chief resident of the Hematology Oncology Department before completing her DM. After completing her postgraduate training, she worked as a senior resident at the Kingston Public Hospital. And since November of 2023, Dr. Barnes has been working as a consultant physician at the Hope Institute Hospital. She's also an associate lecturer in the Faculty of Medical Sciences, Department of Pathology at the UWI. And her dream is to advance cancer treatment in Jamaica through research and education. When not working, she enjoys sports, shooting, playing video games, and lounging on the beach. We're going to give a big welcome to Dr. Barnes. And we're going to see before the presentation that we have a brief poll as constructed by Dr. Barnes for us to participate in. Just answer the poll and Dr. Barnes will direct us accordingly.
Thank you for your introduction, Dr. Samuels. I saw the poll come up briefly and then I don't know where it went. So I'm not sure if everybody has access to it or is able to answer it now.
I see that the poll is up. Hosts and panelists are unable to participate, but it should be up for the attendees.
Okay, so there are two questions in the poll that I had given. One question was on whether or not AI was going to replace us as physicians, and the other question was on AI use and the Data Protection Act. So if you're able to see the poll and you can answer it now, I would like you to give your answer. And then during the presentation, I will address those two issues and then we can see how successful you have been in your answering. Okay, so today I want to discuss the role of AI in oncology care. My name is Tony Barnes. I'm a hematologist and medical oncologist working at the Hope Institute. And this is quite the controversial topic. We have so many news articles coming out every day about AI and AI tools, some positive, some negative, some hopeful, and some quite drastic and frightening. We have the New York Times stating that potentially AI tools are making doctors worse at their jobs. We have our friend Bill Gates saying that within 10 years, AI may replace many doctors and teachers as well. We have some subspecializations that people are being discouraged from pursuing because of the fact that AI may make them obsolete. And then we also have physicians, some of which are stating that they use AI every single day in their lives. Some of them, 89% of physicians stating that they use AI at least once a week. So to get into it, the questions that we had in the poll: does the use of AI contravene the Data Protection Act 2020? Yes or no? And then, can AI replace doctors? Yes or no? So I'm seeing the answers of the poll here. Does the use of AI contradict the Data Protection Act? I see, for the most part, people said yes, and then some said no. So the majority of people say yes, AI contradicts the use of the Data Protection Act. And then the next question is, can AI replace doctors? Yes or no? That one is controversial. That one is tricky. 7 people said yes. The majority of people said no, AI cannot replace doctors. So let's see. It's a point of discussion. So first of all, what is AI? If you're going to use a term, you have to try and define it. Artificial intelligence is the field of computer science dedicated to creating systems capable of performing tasks that normally require human intelligence. And these tasks include learning, reasoning, problem solving, perception, and decision making. In oncology, AI holds significant potential to enhance aspects of oncology, spanning the cancer care continuum. AI is an active clinical decision support tool, but it is not a replacement for clinical judgment. There are numerous potential applications of AI in oncology, including its use on health records management and note-taking, its use in risk assessments for patients, personalized prevention strategies, screening, prognostic modeling, and treatment decision-making. Lung cancer screening and early detection have also been touched by AI, and we spoke ad nauseum about low-dose CT scan, and AI can assist with the interpretation of these scans. Low-dose CT screening reduces lung cancer mortality. We know this, but unfortunately, there are false positives. And two, there is significant inter-reader variability or inter-machine variability. The role of AI in this case is to do things like automatically detect the pulmonary nodules, characterization of these nodules in terms of their size, their shape, their growth pattern, and then come up with risk stratification as whether they are likely to be benign or malignant. The impact of AI thus on these low-dose screening modalities can improve sensitivity for early-stage cancers, as well as reduce unnecessary follow-up scans and biopsies and diminish patient anxiety. This is an interesting study that was done where they took people, a group of expert radiologists, and they compared AI interpretation of low-dose CT scans to see whether there was concordance between the expert panel and AI. And what the study showed was that there was actually very good concordance, and there was no significant difference between the sensitivity and specificity picked up by the expert panel versus AI. Further studies have showed that there was a tool called Sybil, which is a deep learning model. And what Sybil does is it looks at the lung cancer screening, and it was a retrospective study. So basically what happened was that they used the LUNG-RADS clinical criteria and chose only low-risk patients. So patients who were thought to be at low risk when assessed by the radiologist on low-dose CT. Then it ran those scans through Sybil, the AI predictive model, and those low-risk people, sometimes the AI was discordant. Sometimes the AI thought, even though the radiologist said that this was at low risk of being malignant, the AI thought it was high risk. And then because it's a retrospective model, we had the ability now to look into the future to see whether or not these patients actually had lung cancer after all. And what it found is that there were quite a few instances where the radiologist thought it was negative, the score was low initially. 6 years later, 5 years later, these patients actually went on to develop lung cancer. And so Sybil has been quite exciting, a development to figure out patients who are at high risk. So building onto that, different companies have now partnered with AI tech solutions to try to figure out ways in which these AI tools can be used in lung cancer, both in the United States of America and in the UK. Now, there are also prospective AI-based risk prediction models that have been used or are prospective to be used, where they're combining image data with demographics for the patient, such as their age, their smoking history, and their family history. This will hopefully allow for better selection of patients for screening programs and allow us to diagnose more early-stage disease, thus increasing curative intent treatment. Now, many algorithms have shown strong retrospective accuracy, but as yet, prospective trials have not been completed. So for all intents and purposes, these tools have remained untested in clinical application. For diagnostic radiology, this is now beyond screening. We have numerous applications of AI. AI is good at tumor segmentation, which is the assessment of tumor boundaries, the size of the tumor, and accurate volumetric assessments. AI can also be used for tumor response assessment, as AI can detect subtle changes earlier than our usual RECIST-based methods of progression of disease. And it's also useful in delineating between a pseudo-progression of a tumor and true progression seen on a CT scan. We also now have the application of radiomics, which is when you're able to correlate an imaging modality like a CT scan or an MRI with a particular histology. So a radiologist can now look at an image, any kind of image, mostly CTs for lung cancer, and determine what is the histology, what is the subtype, whether or not there are molecular alterations, whether or not these patients are likely to be EGFR positive, and so on. And so this is just an example here using an AI model where they have conducted radiomics. So this and this are both areas of interest, tumor areas of interest. And by putting it into an AI model, they were able to accurately predict in some cases whether or not this was lung cancer and whether or not this lung cancer was EGFR positive or EGFR negative. So that has profound implications on oncology practice. Pathology has also been affected. There is now a subspecialty in pathology called computational pathology, where you can do whole slide imaging assessment. So instead of now having a physical slide, we're able to digitize our glass slides into high resolution images. This has been done in the past, but now with the application of AI, we're able to automatically detect tumors on those high resolution images, and you can do prediction from H&E slides. So in addition to just looking and seeing that there is a tumor, and this is a tumor subtype, and sending it off for IHC or next generation sequencing, you can now predict a driver mutation from the appearance on H&E slides with the use of AI. And this is a significant benefit. It can go towards potentially triaging patients. So if a pathologist has a large number of biopsies to deal with, somebody asks a question about why a biopsy takes so long. A lot of the time, it's just because of the sheer number of biopsies that the pathologist has to deal with at a time. And if you can use AI potentially to triage which of these biopsies is most likely to be malignant, or which of these biopsies is most likely to have a targetable mutation, and prioritize those for further testing, it can cut down on the pathologist's workload, it can allow for faster diagnosis, and it can allow for earlier treatment initiation. This is a AI model that is being used. It's called PAGE. This is not lung cancer, but this is actually a piece of colon. And you can see that they have input this into an AI model, and the AI model is now, integrating or assessing the sample that the patient has, and you're able to tell it to learn, and you're able to ask it what types of tissue it is seeing, whether or not there is tumor. So this is the way that we are going now. For molecular oncology, similarly, AI can be used for interpretation of next generation sequencing data, for example. It can be used to discover new biomarkers for the treatment of cancer, and it can be helpful in assessing tumor evolution. AI models can now track clonal evolution of disease over time, and this has significant potential application for analysis of things like liquid biopsy, where instead of having to do a physical tissue biopsy, you can assay the patient's blood. And now the FDA has actually approved for the first time a model where they're using AI-driven diagnostic tools to decide on the treatments of lung cancer. So the Ventana TROP2 is a device that was developed by the pharmaceutical company Roche, which combines immunohistochemistry with a digital pathology algorithm, basically to decide which patients are eligible for the use of datopotamab deruxtecan, and that is an antibody drug conjugate against TROP2. So this is kind of just the beginning, but this is the first time the FDA has approved such a tool. Now, for treatment and decision-making, AI is a very important and helpful clinical tool. It is a clinical decision support system, not a replacement for an oncologist, as AI can integrate clinical, radiological, pathological, and genomic data. This will allow for better standardization of care and allow for support for less experienced clinicians or doctors that do not have access to specialization. And this is very helpful in Jamaica, where oncologists tend to be concentrated at very specific sites and usually type A hospitals. AI can also be used for predicting treatment response to things like chemotherapy and targeted therapy. It can help to predict if the patients will be sensitive, if the tumor is sensitive and will respond to a particular type of therapy, and whether or not this particular patient will develop toxicity to the chemotherapy, which will then help to optimize the selection of a chemotherapy regimen. For immunotherapy, it can assist with the development of new biomarkers outside of the regular PD-L1 and tumor mutational burden biomarkers, as well as, again, in the development of radionomics. Now, I want to touch on IBM Watson for oncology, because IBM Watson was supposed to be the way of the future, and IBM Watson was supposed to be the doctor killer. So this was supposed to replace you and replace me, and you just have to put in what was wrong in Watson, and Watson would solve all of your problems. Watson was originally an AI tool that was famous for going on Jeopardy in 2011 and defeating the human champion. Because of this defeat and because of the fact that everybody was excited about Watson at the time, they decided to take the same technology and use it at Memorial Sloan Kettering and MD Anderson Cancer Hospitals, which are household name oncology institutions. The AI model was supposed to train with physician data from those institutions and also keep up to date with journal articles, which for oncology are published almost every single day. The problem is that Watson produced basically irrelevant and outdated recommendations. A lot of the time, what Watson said was wrong and had nothing to do with the patient at hand. It was also unable to manage nuanced and complicated cases, and unable to assess medical records, which are sometimes incomplete, sometimes difficult to follow, and sometimes nuanced. This study that I put at the bottom here shows concordance between Watson and expert oncologists at different institutions. You can see that sometimes there is high concordance, like with this trial that they did, only 211 patients though at this hospital in Thailand, and there was 83% concordance. But then, unfortunately, as low as 49% concordance when you increase the number of patients, and they focused only on colon cancer at this hospital in South Korea. So Watson basically, unfortunately, became useless for the use in oncology care. Nowadays, though, they have kind of switched focus where AI is more of a helpful tool for an oncologist. So Open Evidence is a nice program that you have. Basically, all of the journals have input their data into this AI platform. And if you have a question about a specific topic, you can ask it, and it will compile all of the data that they have available on that subject, which is quite helpful. The American Society of Clinical Oncologists has also partnered with Google Cloud in order to build an AI tool that will help you to navigate their clinical guidelines a bit better. For radiation oncology, they have also been affected. The AI has been used for automatic contouring, and this can allow for more accurate delineation of tumor targets, as well as to delineate and cut out organs that are at risk, reducing side effect burden. It helps with treatment planning. It also helps with adaptive radiotherapy, whereby you can monitor the patient as they are receiving treatment. And every time they get treatment, the AI scans the images and sees, okay, based on the reduction in tumor size, I can now plan the radiation in a slightly different way so that we cut out any tissue that we do not want to be overly irradiated. And MVision is one such AI tool that is boasting having gone through 500,000 patient scans in order to assist in their management. For monitoring and surveillance, AI has been developing as well. For the recurrence detection for tumors, AI has been helpful in early detection using imaging and biomarker trends, as well as is prospected to be used in long-term follow-up, whereby it can scan patients' electronic records to assess their outcomes and also assess for toxicity to therapy that we have given. Wearables and digital technology have also started to be developed over time, whereby you can put a little sticker on your skin, and this sticker can assess your blood, check for tumor markers, check your chemistry, check your hemoglobin over time, and feed that into an AI algorithm and determine the probability of you having disease recurrence without involving frequent visits to your doctor. Now, clinical research also has been affected by AI, and we have now seen where they're trying to formulate a framework where patients' data can be placed into AI and you can have automatic screening for trial eligibility. It can also be used in trial design, whereby instead of having one set of patients that are given the new drug or intervention and one set that are given a control, the control potentially can be simulated by an AI so that the majority of patients get the benefit of the new intervention. AI can also be used to predict trial success, and perhaps there is a future where clinical trials don't involve people at all, but only AI models for drug development. Now, there are many, many ethical, legal, and practical considerations for the use of AI. Bias and equity, first and foremost, most AI models are trained on high-income country data. There is a risk of reduced accuracy in low-income and developing populations, of which we are one. Also, training and tech literacy needs to take place with doctors, as clinicians need to understand the AI output. Also, responsibility. AI supports but does not replace clinical judgment. And where does the responsibility lie if AI is wrong? Additionally, the cost. There is cost for new infrastructure, computers, servers, the cost of software, the maintenance of software, and whether or not these are subscription-based models that incur a recurring cost. When I did some research today on how much money it would be to set up an AI-based system in a hospital, for example, I was seeing figures of hundreds of thousands to millions of US dollars just to set up the system. And this does not include recurring costs. So what's in the future? What lies ahead for us? I think that AI can potentially add value. For example, in the radiology sphere, you have AI-assisted CT interpretation, whereby when you see a CT report that says there is an indeterminate nodule of 3 millimeters. I have received many a CT report of that nature. If AI can assist in the delineation of those nodules, I think that would be very helpful. For pathology, I think using AI to triage H&E slides can be very helpful. Triage in which one of these slides is most likely to be cancerous. Can I push that result out first? As well as which one of these slides is most likely to be positive for a targetable mutation? Can I send those off for molecular testing and then save the money of the people who are most likely not to have a targetable mutation? And then AI can assist with treatment planning. So you can have it for decision support for oncologists who are managing complex cases and do not have access to subspecialty MDTs. So those are available at Type A hospitals, at large teaching institutions. UWI has an MDT, KPH, but smaller sites do not. Can AI help there? Can we do regional data sharing? We have CAHO. Can an AI model help us to integrate all of our data, and then we can search and do research with our data on an AI model that has been trained on our specific subpopulation? Can I now, with treatment planning, do personalized treatment sequencing of my patients, where I input my patients' clinical data, their family history, their risk factors, and get a personalized treatment plan for them? And this helps too to extend subspecialty expertise into low resource settings, hospitals that do not have an oncologist, or oncologists that have not seen certain types of cancer very readily or commonly because our population is small. There are challenges for AI. I think number one being inaccuracy. What happens when the AI system is wrong? Who is to blame? And what about medical indemnity? I will tell you that when ChatGPT was just coming on stream, I decided I wanted to try it, and I asked it a question about something that I knew. I know a lot about breast cancer, I treat breast cancer all the time, and I asked it a breast cancer related questions, and I asked it for evidence. And when I tried to follow the links for the breast cancer trials, the trials were wrong. It was citing trials that did not exist, or the answer in ChatGPT said that the trial was explaining one thing, and then when you check the trial, it actually was explaining something completely different. So inaccuracy is very serious, and I know the correct answer, so I was doing it to test it. But what if it's a physician that genuinely does not know the answer to a question and is asking, and the AI gives you the wrong answer? Who is to blame? Physician and education and adoption are going to be difficult too. Some of our physicians do not trust technology. They want to write their notes by hand. They have physical dockets still. What happens with doctors like that? Do they get left behind? And it does not necessarily help to reduce resources. It merely shifts resources. So now, maybe you have a medical institution that is doing radiology, and you used to have 5 radiologists, and you decide you're going to have 2 radiologists and an AI system. But now, instead of having 5 radiologists, you have 2 radiologists, plus you need a chief of IT, and you need engineering staff, and you need maintenance personnel, because now you have all this equipment, and there's still people that are involved in the management and maintaining of that equipment. Data privacy and security, of course, are difficult challenges as well. So for the Jamaican perspective, our current challenges for oncology care are that we have limited access to subspecialty physicians. Basically, all of our oncologists are general oncologists because there are not enough of us for you to remove yourself from the pool and focus mostly on one type of cancer. So people go and they do fellowships and subspecializations, but they still have to practice general oncology. We also have limited access to molecular testing and next generation sequencing. All of our samples have to go to Miami, and we have limited access to clinical trials. Also, our patients tend to present at a late stage, and we have many resource constraints and workforce shortages. There is a lack of legal framework to deal specifically with AI, and there are concerns about data privacy and governance. So, and as before, does the use of AI contravene the Data Protection Act? So let's look at the Data Protection Act. I'm not going to make us read through the whole thing, but I did pick out some relevant subsections that I thought dealt potentially with the subject of AI. So subsection 9 is consent to processing. Any consent required to be given by a data subject to the processing of personal data means any informed, specific, unequivocal, freely given expression of will by which the data subject agrees to the processing of that data subject's personal data. That basically has to do with consent that the patient gives you to use their data for anything, to write it down, to put it in an AI tool. So it does not say AI specifically, but I do believe that this part of the act would deal with you getting consent to then use your patient's data for something else, be it a clinical study, be it for an AI tool. Number 10, or subsection 10, speaks about a data controller not processing personal data of a data subject for the purpose of direct marketing. Now, a lot of the tools that are online are free of charge, meaning that we do not pay Google and ChatGPT to use their services. However, anytime you don't pay for something, you are the product. So we are giving these companies access to our data or to our patients' data. And they potentially are storing this data, maybe in the future for marketing purposes. Another part of the act speaks to rights in relation to automated decision taking. And I think this is the closest that they're coming to speaking about something called AI, although I don't think that that's what they intended it to mean. And it applies to basically using the data in order to have automatic decision making be done. I think that if you feed data into the AI and the AI therefore makes a decision, maybe calls the patient in and tells them that they need to come in for special screening or they need special investigations to be done, that could come under subsection 12. And then there are other questions that I think the Act does not fully deal with. If I put my patient's data into an AI engine, but I do not use identifying information, how does that fall? What does that do? If I just put a 45-year-old man with a T3N1 lesion and I put in their images, it's still them, but it cannot be traced back to them, maybe. Maybe it doesn't have identifying information. Does that fall under data privacy? It's difficult for me to tell. I don't know. I'm not a lawyer, but maybe these are questions that we need to start asking. And maybe they need to amend this act because it was in 2020. And I think the AI boom has occurred maybe most significantly over the past 2 to 3 years. So the time has now passed. Now, another question I had in the poll was, can AI replace doctors? Most people said no. And I agree, but what I decided to do was ask ChatGPT what it thought. I said, ChatGPT, is AI going to replace doctors in cancer care? And ChatGPT said no. AI is not going to replace doctors in cancer care, but AI is profoundly transforming how cancer care is delivered, and it's important to understand both the opportunities and limitations. It goes on to say what AI does well, which we spoke about before: diagnostics, imaging, pathology, prognostication. And it speaks about what AI cannot do. AI lacks clinical judgment. There is no human empathy from AI. There is a data bias and problems with safety, especially if the AI trained with a population different to yours. And there is a lack of responsibility and accountability. So in summary, it speaks about the role of AI and whether or not it replaces doctors. And the answer is no. AI will make cancer care more precise and efficient, but AI will not replace the clinical expertise, human judgment, and compassion that doctors provide. So the take-home message is, AI is already influencing cancer management on a whole, but as I showed you, lung cancer especially, there is strength, I think, in data integration when you're able to put in imaging and clinical data together. Radiologists, pathologists, and oncologists still remain central to decision-making, but may be assisted by AI tools. And responsible implementation is key. So thank you very much for your attention, and I will take any questions now.
Thank you, Dr. Barnes, for your very timely presentation on AI. I suspect we'll be hearing many, many more things about AI in the months and years to come. And as the technology advances, we'll be hearing more. What I tell the residents on my team is, one, they shouldn't use AI if they're able to avoid it. But when they do use it, I advise them, use topics that you're more familiar with, right? If the topics are on the edge of your specialty, if you're just not familiar with it, it's very dangerous because it's going to present to you very good sounding topics, very good sounding arguments that you might not be fully aware of or fully familiar with. And you won't necessarily have the ability to judge them. Because as you said, my experience, when you ask it about something you know and you inspect it for why it's making these decisions, it can't necessarily back up the decisions or the resources that it gives you. The references that it cites are not accurate references. So you really do have to be very careful that it doesn't hallucinate and give you something that you regret doing if you ask it something outside of your scope.
Yeah, I think that one of the most helpful things that AI can do is it can help to organize you if you're not sure where to start, it can kind of help you to organize your thoughts a bit, and it can give you a starting point for your own research. But you still have to do your own research because it is very good at sounding like it knows. And then when you fact check, very frequently it is wrong. So you have to be very careful.
We have a question from Dr. McDonald. Great presentation. Are the wearable devices available in our settings?
I believe that they are still mostly in development. What I have found has been some integration of AI into things like smartwatches that are already available. So people's Apple Watches and their Garmin's, their data can be fed into programs where maybe it takes out your blood pressure and looks at trends over time, or maybe it takes out your heart rate and looks at trends over time. But for the most part, those are tools that you have to subscribe to, or your hospital would have to have built out a framework. So most of these things are available to physicians in the United States or in first world countries. I have never seen anything available in Jamaica outside of maybe the regular Apple app, Apple Health, and so on.
Okay. How can we prevent false positive results from AI? Any good practice notes or any insights?
I think it just has to be used in combination. So you have to use your own clinical judgments and combine it with the results from AI, because what it can cause is a lot of undue anxiety, especially. For the most part, when I looked at the trials and the studies that were done on AI, they were concordant, meaning that it was just as good as the doctor, but very rarely did you see any AI tool that was better at clinical discernment than a physician. Maybe just that lung cancer trial where they had the extremely small nodules that AI was able to pick up. But the false positives are very concerning, and I think that's why these tools have to be used with a physician and not the patient by themselves going and inputting their data in something and then coming back very scared because of something that AI told them, which is very often incorrect.
All right. We have a couple comments from members of the audience. Dr. Morgan says, I look at AI almost like how I choose which news or media sources to trust. If you have no bearing on what is true and what is just, you may be more inclined to believe false information. And Dr. Hamilton thinks AI can definitely aid in the quicker analysis of pathology samples from biopsy. Are there any more questions for Dr. Barnes? All right, if there are no more questions, I'd like to thank Dr. Barnes for, again, another excellent presentation. Whoever chose the topics for this conference was very good, right? 10 out of 10, all the way through. Great presentations by our panelists and great topics, everyone. I want to thank all of you guys for coming to the conference. There are 3 CMEs on offer. We will email your CMEs to the email address associated with your registration and to the email addresses listed in the YouTube chat. I want to remind everyone as well that the Jamaica Cancer Society will be having a colon cancer medical symposium on Sunday, March 15, 2026. Registration will be available on the Jamaica Cancer Society website later this week. That's Sunday, March 15, 2026. So consider this a save the date. Once again, thank you to all our panelists. Thank you to our organizers and volunteers. And thank you to all our attendees. This has been a wonderful evening. Good day.
Thank you very much, Dr. Samuels, and thanks everyone for coming. And we ask that you remember to just put your email addresses in the chat so that we can send out the CMEs actually for 3 hours and 1 hour of ethics. Thank you.